Join the PRS Journal Club. Read the monthly picks and classic pairings on PRSjournal.com. Discuss with the authors on Twitter at PRS Journal and listen to the podcast.
Hi everyone, and welcome to the October 2017 inaugural Masters Edition of the PRS Journal Club podcast. My name is Jordan Frey, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassadors, Shuja Shafqat from the Fox Chase Cancer Center and Chad Purnell from Northwestern. So today we have the honor of being joined by Dr. Rod Rohrich, Editor-in-Chief of Plastic and Reconstructive Surgery and Professor and Founding Chairman of the Department of Plastic Surgery at the University of Texas Southwestern. Thank you very much, Dr. Rohrich, for joining us for this special Masters of Plastic Surgery edition of the PRS Journal Club podcast.
My pleasure and honor to do so.
So the article we'll now be discussing is entitled Extended Alar Contour Grafts, an Evolution of the Lateral, Crural, Strut Graft Technique in Rhinoplasty. And this is from Drs. Cochran and Sieber from UT Southwestern. And as a reminder to all the listeners, all of this month's articles can be read for free on PRSjournal.com, and this is including an archive of all the past Journal Club articles. We'll go over a brief review of this article before getting into what I think will be a great discussion. So in terms of an introduction, the authors discuss that modification of the lower lateral cartilage complex is the sine qua non of modern rhinoplasty, and the open approach to rhinoplasty has expanded the techniques available to help achieve an aesthetically pleasing tip, which has been described, as we know, as having a diamond-shaped configuration with lateral points formed by the tip-defining points, a superior supertip point, and an inferior point being the columellar break point. And the lateral crura are highly variable in their shape, orientation, contour, thickness, and the authors go into some of the anatomy, which I think is important, in that the lateral crura are frequently connected to the accessory cartilages and connective tissue, linking them and causing them to act as one structural and functional unit. Their lateral extension often abuts directly against the piriform aperture, and the lateral crura form only a small segment of the alar rim. Without proper orientation, the lack of lateral support from the alar sidewalls can cause an inward movement of the alar rims, which can result in a vertical shadow and result in the isolation of the nasal tip, resulting in various deformities of bulbous tip, parentheses, deformity, and pinch tip, all sort of related. And this is frequently observed in previously operated noses. There are various methods which have been described to minimize and mitigate tip isolation, with the most popular being lateral crural strut grafts, alar contour grafts, alar strut grafts, subdomal grafts, as well as various suturing techniques. Lateral crural strut grafts, because of their fixation to the lateral crura, are perhaps the most versatile grafting technique compared to alar contour grafts, which, because of their position along the alar margin, are perhaps most effective in supporting the alar rim. And the lateral crural strut grafts were originally described by Dr. Gunter as laying beneath the entire lateral crus and extending over the piriform aperture. And this evolved to extend these grafts only to the accessory cartilage. However, this still left a significant portion of the alar sidewall caudal to the lateral crus, and importantly, the alar rim without support. So the senior author and Dr. Gunter then described creating a pocket for the lateral crural strut graft more caudally within the alar sidewall. Alternatively, use of alar contour grafts was really popularized by Dr. Rohrich to help prevent and correct alar retraction or collapse, as they're placed in a subcutaneous pocket immediately above and parallel to the alar rim. However, because they're not secured to the lateral crus, it does not provide lateral crural support or necessarily influence lateral crural orientation. So in describing all of this evolution of prior techniques, the authors then presented their technique of the extended alar contour graft, which represents a further evolution of the lateral crural strut graft and its marriage really to the alar contour graft. The authors describe their operative technique, and they provide excellent figures and a video doing so, which I would recommend checking out. But basically, these extended alar contour grafts are structural grafts that are placed along the alar rim, similar to an alar contour graft, but they're fixated to the undersurface of the lateral crus near the dome, and this is similar to the lateral crural strut graft. To do so with an open technique, vestibular skin is then undermined from the lateral crus from the dome to the lateral crus cartilage, accessory cartilage junction. A pocket's created from the alar rim along from the soft triangle to the alar cheek junction using sharp scissors, and then the extended alar contour graft is fashioned from autogenous cartilage, preferably septal cartilage, but auricular or rib cartilage can be used, and it's made about 1.5 millimeters in width and 20 millimeters in length. And this is then advanced into the pocket, insinuated under the dome, and secured to the caudal margin of the lateral crus using 5/0 vicryl suture. So the authors in their discussion then mentioned that really this extended alar contour graft combines many of the positive attributes of the alar contour graft and the lateral crural strut graft. As similar to the lateral crural strut graft, it provides support to the caudal edge of the peridomal lateral crus, causing a lateral rotation and forcing the lateral crus into a favorable orientation. But as an advantage, compared to these traditional lateral crural strut grafts, they require less cartilage. Similar to the alar contour grafts, they're placed low along the alar rim, which helps prevent and correct alar notching, retraction, or collapse. But migration is also minimized as there is fixation to the underside of the dome. Importantly, the authors list in their mind the main indications. They list 6 in primary or secondary rhinoplasty for these grafts, with one being prophylactic use to prevent alar rim collapse or retraction, then non-prophylactic use to correct alar retraction, alar notching, alar collapse, as well as correction of a bulbous or boxy tip, and to help cephalically oriented or malpositioned lower lateral cartilages. They do mention some limitations of the technique. There is a potential for alar base widening. You are not able to affect change in overconvexity or concavity in a craniocaudal axis of the lateral crus, and as always, there's a possibility of peridomal abnormalities if they're not properly secured. So overall, I thought this was a really interesting and very well-written techniques article. As the authors did a great job of summarizing, the lateral crural strut grafts and alar contour grafts are very powerful techniques to refine and correct alar pathology, as was popularized by Dr. Gunter and Dr. Rohrich. And this evolution of the extended alar contour graft is logical in its technical design and implementation, combining the positive aspects of these grafts to help minimize tip isolation, either prophylactically or when it does appear, to correct it. And like I mentioned, maybe most importantly, the authors provide excellent figures, so it's very clear as they're going over their technique, what they're doing, and there's a great video demonstrating the technique that's really helpful for novice rhinoplasty surgeons and especially residents like ourselves. So I look forward to the authors describing their outcomes with this technique in the future. So Dr. Rohrich, I'm really interested to hear what you thought about this paper.
Well, it's actually been a marriage of the best of both techniques. I mean, I've actually used extended alar contour graft now for years as well. And, when I first described the alar contour graft as a bridging segment in a primary rhinoplasty for a little alar notching or preventing it, this is actually what I use the extended alar contour graft in probably 95% of my patients today. It's the one graft that I almost uniformly use. And the only difference is I extend it all the way to the peridomal area. In primaries, many times I don't fix it, because anytime you fix a graft like this, then it adds some rigidity to the tip. So what I do is I actually put an extended alar contour graft in, then I just fold over the skin in a primary rhino and then see how it looks. In a secondary, I'll fix it because I need that additional support. What fixing it does under the domal areas, it does give you a little more support, especially if there's some bowing in that area. But in primaries, you don't need to do that in most cases because, and this is it's in press. It's called the infratip lobule or the butterfly graft, where you're beating the extended alar contour graft with an infratip horizontally placed. It's a cephalic trim butterfly graft. So you're actually getting that infratip lobule pushed out and closing dead space, matching the extended floating alar contour graft. But I think this is a great rendition of the lateral crural strut. The reason I like the lateral crural strut, it's very powerful, but the problem was it took so much cartilage, a lot of undermining, and many times what they didn't mention in this article is that sometimes it actually caused external nasal valve collapse because it actually pushed inside the nose so much that you could actually collapse the external nasal valve. So that's one thing that I just want to point out. But it's a very powerful, useful technique. And, of course, I strongly encourage Drs. Cochran and Sieber to write this up. We're glad to have it in the White Journal.
Those are all excellent points, and I think it just speaks to how powerful these kind of grafts, and especially alar contour grafts or extended alar contour grafts, in rhinoplasty, as you hear, like an expert, if you're using it in upwards of 90% of your cases, obviously it's a really important thing that we should all be considering as we're learning to do rhinoplasty and evaluating these patients. A bit of an offshoot question here, but with regards to tip refinement, such an important part and a nuanced part of rhinoplasty, what in your mind are the 3 most powerful techniques that we should learn during our residency to have in our arsenal if we're going to become rhinoplasty surgeons?
Make sure the septum's straight. number one. The key to a straight nose is a straight septum. So make sure you have a straight septum. And then the foundation for building a straight tip is multiple sutures with and without a columellar strut. I think we use columellar struts too much. I think a low intercrural suture, middle and high intercrural, and then setting that high intercrural suture so you can reshape the infratip lobule. Many times in primary rhinoplasty, you can set the infratip lobule suture so that it shapes that infratip lobule so you don't need a tip graft. And then placement of intradermal sutures, and then, if needed, transdermal sutures caudally placed. Because the great thing about open rhinoplasty, you can actually test yourself and redrape the skin and see whether you've passed or not. And the most powerful things are straight septum, intercrural sutures, and then the three powerful sutures, intercrural, interdermal, and transdermal, without a tip graft in most primary rhinoplasties. If you master those three things, you will master tip rhinoplasty.
Well, thank you. Great pearls that we're picking up. Shuja, what did you think about this paper?
So I actually thought it was a very good paper. I thought it was well-described technique. I feel like every time I read an article on rhinoplasty, I pick up something new to look for or deformity to notice, and this article certainly did that, looking at positions of lateral crura. You know, they state that these deformities of the lateral crura can lead to tip abnormalities, which are frequently indicative of prior rhinoplasty, which kind of tells me that a lot of times these issues may be overlooked in primary rhinoplasty patients. So again, I think it's a good exam finding or something to look for when we do our nasal analysis. And the thing I thought was best about this paper is that the authors, I think, were pretty honest in stating what the extended alar contour grafts are good for and what they can't accomplish. So, you know, it's easy to understand that they can correct malposition, but it's obviously hard to imagine how, if these grafts aren't secured to the underlying lateral crura, especially more posterior as you approach the piriform rim, you know, it's hard to imagine how they would adequately correct convexities or concavities of the lateral crust. So I think that they did an excellent job in their discussion of stating that, what the limitations of this graft is and what it can and can't be used for. So I thought it was very good. So Dr. Rohrich, my question to you is, I know you've mentioned this when we talked about alar contour grafts in the very first journal club, but can you talk a little bit about precise pocket dissection and with all the techniques for addressing the lateral crust? Is this something that always mandates an open technique? I know you frequently talk about open rhinoplasty, but certainly some people talk about closed rhinoplasty. Does this mandate an open technique? And then can you talk a little bit about precise pocket dissection, especially if you aren't securing these grafts?
I think alar contour grafts can be placed closed as well. The key is placing them in the infratip lobule in the infracartilaginous position. In fact, many times in secondary rhinoplasties, when I've done a strong extended alar contour graft and I still have some bowing, I'll put in a retrograde at the alar base on the inside. I'll put in a retrograde extended alar contour graft kind of as a double layer, and I'll do that closed when I'm done. And I'll just make a little pocket and undermine it and push it in there. It's beautiful. The key is a precise pocket and then placement and then closing it at the entrance point. I mean, I think it's a great technique to use in open and endonasal. It's very powerful. The key is precise pocket placement and spanning the defect.
Great, thank you. Chad, what did you think of this article?
I thought this was a great article. I agree with you, Shuja, that rhinoplasty is such a complex operation, and I think that even now as a chief resident, I'm still barely scratching the surface of what rhinoplasty is all about and patient evaluation for rhinoplasty, and then addressing the deformities that you notice and you've evaluated. And I think this is another really well described, with great pictures and great video, technique. And I think this is definitely a technique that I'm going to try and incorporate whenever I'm doing my next rhinoplasty, as long as it works well for the patient. This is definitely a really good technique. I think it really does merge the best of an alar contour graft and a lateral crural strut. And so for a patient who doesn't need quite the same level of support as a lateral crural strut, I think this is a perfect technique. So I really enjoyed the article. Dr. Rohrich, one thing that I wanted to ask you was, it's been a while since that very first journal club whenever you were discussing alar contour grafting. And I think with everyone who's doing a lot of rhinoplasty, there's a lot of evolution in technique. So is there anything that you've changed about your technique since that first journal club where you were discussing your rhinoplasty technique and alar contour grafting?
Absolutely. The key is, and I think you all mentioned it, I learn something new about rhinoplasty every day, and I do it almost every day, 2, 3 a day. Of course, I change the technique because, my best CME and my best outcome is seeing my patients and looking at my documentation and saying, you know what, that alar counter graft was too short. So I almost uniformly put an extended alar counter graft, precise pocket. The other thing that's not mentioned in this article is that when you're placing an extended alar counter graft, make the precise pocket all the way to the alar base, because the longer it is and the tighter the pocket, it in essence acts like a fixed pole and then pushes it out. So you don't need to be doing a lot of fixation at the abdominal area, because the things that I don't like is fixing. I don't like the rigid nasal tip, especially in a primary rhinoplasty. In secondaries, of course, that's one of the sacrifices you get to reconstruct the tip. And I would also make a plea to everybody that's listening on this podcast is that when they're done with their operation, if they're on their base view before they close, if they're not totally triangular, if there's any hint of notching, they need to do one or two things. They need to take the sutures out where they're closing the infracarditis incision, or they need to add an alar counter graft. And if you do that, it'll be an epiphany for them, and it'll change their results forever. The other thing is, the base view used to only be important for plastic surgeons, dogs, and lovers, but now it's important for selfies. So the millennials love this view because they're taking selfies all the time. So I see more patients every day because this view is so critical to them. So just remember that. It used to not be that important, except for us as plastic surgeons, but now in the selfie millennial time, it is critical to get the alar base view perfectly triangular.
Thanks. I never really thought about that, but that's totally true. The basal view is a lot more noticeable when you're taking a selfie. So that's a good thing to think about.
I think in all that was really an incredible discussion, and I know I learned a lot. I think everyone listening will, but I think with that we'll end our discussion of this article. And to everyone, remember to tune in to the other 2 articles that we'll be discussing on this month's podcast, as well as all of our previous and future podcasts broadcast every month. And don't forget to participate in our monthly hashtag PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected articles' authors. And once again, Dr. Rohrich, thank you so much for joining us for this inaugural Masters in Plastic Surgery Journal Club podcast. We really enjoyed it.
Well, I want to thank the 3 of you. You've done a phenomenal job advancing PRS. I'm confident that the future of plastic surgery is secure with folks like you at the leading edge. So keep it up.